This is a health assessment video to help guide you as you are starting to do head-to-toe assessments on your patients. It'll be critical that you follow the steps involved so you can get an accurate, thorough assessment. When you're doing any head-to-toe assessment, it is going to be important that you do 4 main things. You inspect the area, you look at it, see if there are any abnormalities, you'll palpate, you will be applying light pressure with your fingertips to feel for any sensation differences. You will percuss, which is a slight tapping motion with your finger to assess for any fluid within the tissues. Or you will also auscultate, which is listening with your stethoscope to listen for any abnormalities as well. Hand washing is an essential component of any health assessment when we're going to be having contact with our patients. It's important to do a thorough assessment before you have contact as well as after you have contact with each of your patients. After you have washed your hands, it is time to go in and meet your patient. When you're introducing yourself to your patient, it's important to tell them who you are and the reason for you being there, also using 2 forms of identifiers to make sure that you know that you are assessing the correct patient. Once you have completed that and let them know that you are there to do the health assessment, one of the first things you're going to do are going to be a set of vital signs. Vital signs include temperature, pulse, respiration, and blood pressure. Pain is also the 5th vital sign that we need to assess. With pain, there's a PQRST mnemonic that we can use to remember the different aspects of pain assessment. P stands for provoke. What provokes the pain? What brings it about? What makes it worse? What makes it better? Q stands for the quality of the pain. Does the patient describe it as sharp, stabbing, dull, or an ache? R stands for radiates. Does that pain radiate to anywhere else within the body? S is the severity. In general, we have the patient rate the pain on a scale from 1 to 10, 1 being very minimal pain with 10 being the worst. There are also other forms of pain assessment or pain assessment scales that can be used, such as the Wong faces. Whatever the scale that is used, if the severity of pain is usually around a 4 or greater, then some form of intervention needs to be done. Now, it's also important to remember that after the intervention, we need to go back and reassess that pain within 1 to 2 hours. As you're doing the vital signs, it's also important at this time to do what we call the general survey. And that's basically looking over her and getting some information just based on how she is presenting herself. That includes general appearance. What are the facial expression? What about grooming or their dress? Are they acting and behaving appropriately for the situation that they are in? Mood and affect is another thing that we look at. Are they depressed? Are they happy? Is it appropriate for what they are experiencing while they are there? Posture and movement is another thing that we will be looking at. How do they hold themselves? How do they carry themselves? If the patient is in the bed, we may not be able to tell that as much, but as we care for them throughout the shift, we will be able to pick more of that information up. Once you have finished doing the vital signs and the general survey, we move on to the head-to-toe part of the assessment, which starts with the neurological assessment. When we're assessing the neurostatus, it's important to ask person, place, time, and short memory questions to see if they're responding and remembering what is appropriate for the day. Some questions simply are, do you know who you are? Do you know what time of day it is? Do you know what day of the week it is? Any patient who is starting to have any problems with short-term memory will actually start not to remember some of the things that are a little bit further in distance. Something as simple as what they had for breakfast that day or supper the night before. If there is an alteration in the level of consciousness, if they are sleepy, if they are not able to awake them, or more drowsy than what we are used to, those are signs that indicate more intervention or more action needs to be taken. The Glasgow Coma Scale is a scale that we use to determine level of consciousness and neurological assessment. You will find a slide that will go through some of the details of more of the specifics of what we're looking for. With the Glasgow Coma Scale, they look at eye response, verbal response, as well as motor response. And we rate the patient according to each of those on how well they do and how well they respond to those 3 different areas. With the Glasgow Coma Scale, they are given a number, a rating, anywhere from 0 to 15. 15 being a normal assessment with no neurological deficits. whereas anything less than that, there is a little bit of something that's going on with a patient that may need further evaluation. As you see the slide, it gives you more detail as to what to look for with those things. With the neuro assessment as well, we need to look at different nerves throughout the body that are being affected. One of the things that is done simply is looking at facial expression. Is there symmetrical movement with the eyes when they blink, with the face when a person smiles? That gives them an idea of neurological status. Communication and speech also fall into this category. How clear is their speech? Do they slur their words? Do they communicate effectively? Are they able to say what they are trying to say, or are they stumbling over their words? Those are all very important assessments to look at. Another thing that needs to be done with the neurological assessment is eye movement. When you walk around the room as a nurse, do they follow you with their eyes? Are they able to make eye contact with you, and is it appropriate? Also, pupil reaction. If you have your pen light, an important thing to do is to assess the pupillary reaction that occurs. Basically, from the side, you bring the light in, watch for pupil constriction. If the pupil constricts on both sides, that means normal neurological movement for the eyes. When you have completed that, that basically completes the neurological assessment. We will then move on to the head. When you're assessing the head, again, you've been doing this throughout most of the assessment, but it's good to look at it a little more closely, especially with the hair. Is the hair well groomed? Is it clean? Is there any dander or lice that is present? When you're looking at the eyes, you've done the pupillary reaction check. Now we're just checking for any asymmetrical movement, any drainage, redness, swelling located with the eyes as well. As we move down to the nose, look for symmetry. Observe if there are any nasal passages or patency. You may have occlude one side of the nostril and have the person take a breath. And if they are do fine, occlude the other side and have them take another breath. That determines the patency of the nasal airway. For the mouth, when we're looking at the head and the face, make sure that we're looking at the gums and the teeth. Have them smile, have them open their mouth for you. Do they have dentures? Do they have any partials or false teeth that we need to be concerned about? Also look at the gums. Are they receding? Are they red? Are they swollen or irritated? At that point too, you can have them open their mouth and look in their mouth. And you can see, if you need to use your pen light, feel free to use that. But make sure you're looking for different open sores, redness. Look at different places within the tongue. Are there any abnormalities that you might want to note with that as well? Also with the mouth and the nose, many times when you're taking care of a hospitalized patient, they may have a tube, an NG tube, either through the nose, or they may have an orogastric tube that goes through the mouth. So it'll be important that we determine the patency of that tube as well while we are doing the assessment. When we are looking at the mouth, we want to make sure that it is moist enough, that there are no cracks within the tongue or the cheeks or even within the lips. That is one of the first signs of dehydration, is when the mucous membranes become too dry. So it'll be important for us to assess that. Also, many times when our patients are in the hospital, they are there for a reason. Maybe it's dehydration, or they have different things going on within their system that they may not be able to stay hydrated well, or they may not be able to take care of those cares for themselves. So as a nurse, it's very important that we monitor those and provide the best oral hygiene that we can. Once we have finished with the mouth, one other thing that we often do is check gag reflex and swallow. Now, frequently we don't do that separately within the assessment because we have given them medications earlier, and we will do that when we check their medications, or we want to give them the medications. We'll make sure that they have a gag reflex and they're able to swallow without coughing. So if you haven't done that, now it might be a good time to do that prior to your documentation. Once you get done with the head, we move down onto the neck. Basically with the neck, we're just going to be inspecting. We're going to look for symmetry or any masses or scars that might be available. We're also going to palpate. Right under the jawline here, there are some lymph nodes. So it'll be important for you to palpate those lymph nodes and ask the patient if there's any tenderness or pain as you are palpating, which can indicate an inflammation within that lymph node system. You may also want to feel for any masses that may be present. Throughout the entire assessment as well, we are also looking at the integumentary system, or the skin. There are many things that the skin can tell us. It can refer us to hydration status. It can also tell us if there's any open areas, which could be an open place for infection to enter the body. So as we're looking at the skin, we want to look at color. Look at the color and pigmentation. We want to see if there's any lesions, if there's any bruising, papules, nodules, any ulcers that may cause the skin to break down and cause additional peeling and swelling that we want to assess. If there is any lesions present, we want to note the location of them and actually measure the size and document those accordingly. Skin integrity, like I had mentioned, needs to be assessed. That's the intactness of the skin. If there are any catheters through the skin, if they have an IV catheter, we'll want to make sure that we observe that area, assess for any redness, swelling, or drainage that may indicate an infection. If a person is bedridden, we are also going to want to look for pressure sores, areas that may break down just from immobility. So we'll want to make sure that we look at the elbows, the sacrum, behind the backside, behind the knees and lower legs, as well as the ankles. Any pressure areas also that may be caused by the drapes hitting the patient, we'll want to make sure that we look at those. Once the skin becomes reddened and starts to break down, it becomes very hard to reverse that process. So prevention is the best way to do that. As we are looking at the skin, another thing that we can note by feel is the vascularity of the site. Is there good blood flow through the extremities? If an extremity is warm to touch, then there's good blood flow through the area. If it is not warm to touch, that can mean there's some vasoconstriction going on, which can also lead to increased breakdown of the skin. So we need to monitor that closely as well. Another thing we do with skin is measure the skin turgor. Skin turgor basically is when you grab the skin and pinch the tenting that appears. That tells us about hydration status. When a skin turgor is pinched and it goes back down immediately to the body, that means the person is well hydrated and there is not a whole lot of need at this point to worry about fluid volume deficit. If, on the other hand, tenting occurs and it stays there, we need to worry about dehydration and may need to look at other methods to make sure this patient is getting enough liquid. When we are doing our skin assessment, wounds. If the person has had surgery or if there are any staples or sutures from previous injuries that we need to be assessing, it's very important we look at those and we document those. Again, the location, their appearance, and any drainage or redness that is there. We also need to make sure that we are measuring those wounds to make sure that they are healing and demonstrating healing within our documentation. As we continue to move down in our head-to-toe assessment, the next step is the chest and the thorax and the respiratory system. As we are inspecting this area, if at all possible, it's best to remove any clothing that might be there so you can get a visual examination of the actual skin and there won't be obstructed by any clothing. For this purpose, we will have the clothes stay on, but it's important to look at the symmetry, note any deviations within their chest. Is that person barrel-chested, which means their chest is more rounded? Is there symmetrical movement of the chest wall? Is there any bulging of the intercostal spaces in between the ribs or retractions? So it's best to note that. Also within the respiratory assessment, you need to know your normals. What's your normal respiratory rate? It is 12 to 20 breaths per minute. Normal pattern is going to be easy breaths in a regular rhythm. Also note the depth of any respiration. Are they very deep or are they really shallow? Sometimes respirations can be affected by anxiety or by pain, or even if they know that we're watching them. So it's very important that when we're assessing the respirations, we do it without them really knowing what's going on. Also, when we're doing the respiratory assessment, it's important to note if they have any oxygen, whether by nasal cannula or by face mask, that we also assess that it's flowing at the correct rate, and that we're also looking at their O2 saturation, so we make sure that that is within normal range as well. Normal for that is 96 to 100%. We need to palpate. One of the things you need to do within the chest. Palpation needs to take place on the anterior and the posterior chest. When we palpate, we're palpating for any tenderness or also any chest excursion, swelling, or crepitus that may take place. Make sure that when you do that, like I had mentioned, you need to do it on the anterior as well as posterior chest. The next thing you need to do is percuss. When we percuss the chest, we are listening for the different sounds that fluid makes versus air makes within the body. So when you percuss, you need to go in between the ribs on the front or in the back, start at the top, and listen as you work your way down. What you should hear should be more of a resonance in sound. If you hear any dullness, that can indicate there's fluid or a mass in that area, and further assessment needs to be done. Once you have percussed, then it's going to be important to auscultate, to listen to all those lung fields as well. You need to listen on the anterior chest as well as the posterior chest. The lung apices themselves actually go above the clavicle, so it will be important to start high when you're listening and work your way down. When you're listening, have them take a deep breath. Can you take a deep breath? And exhale. And again, and exhale. And again, and exhale. And again, and exhale. Throughout the process, it'll be important to compare bilaterally and side to side to make sure that the lung sounds are the same on both sides. It also gives you a good comparison, as if one side has fluid in it and is working better than the other side. Diminished or absent breath sounds occur with shallow respirations, if there's fluid in the lungs, if there's obstruction or even hyperinflation. A mass or consolidation can also be a reason for diminished or absent sound, so it's important to listen carefully and frequently to make sure that you are making that assessment accurately. Adventitious sounds are something we hear frequently within the lungs. Some of the adventitious sounds that we talk about include crackles, rhonchi, wheezes, or even a pleural friction rub. And when you hear those you need to document those as well, so we can make sure that the appropriate care is provided. When we are listening, make sure you always listen to anterior as well as posterior, and you document where you heard those sounds accordingly. Other things to note when doing a respiratory assessment includes cough. Do they have a cough? Is it productive or non-productive? Is it dry? Is it bothersome? Is it only when they're eating or drinking? Or is it random? If they are producing sputum when they are coughing, we need to make note characteristics of that sputum. What is the color of the sputum? Is it consistency? How much are they coughing up? Is it every time they cough or not? Also dyspnea. Are they having any difficulty breathing? Is there any bloody sputum that we need to be concerned about? Also wheezing and chest pain are all areas that need to be noted within the respiratory assessment. When you're completing the cardiovascular assessment of the patient, we're going to be specifically focusing on the heart. As you're inspecting, you need to look at the mediastinum, the front aspect of the chest, and we're going to also assess the 5 landmarks for pulsation or lifts. Also, at this point, if you have not done the jugular vein distension, you may do that at this time or later in the assessment as well. When we are listening, at different times, there are 5 different landmarks we need to listen to when we're auscultating the patient's chest and their heart. The aortic sound, when we listen to the heart, you need to assess where their ribs are and count down to the 2nd intercostal space, right sternal border, and listen and count the heart rate that you're hearing. Make sure you're not hearing any murmurs or additional sounds within that heartbeat. Then you'll move over just to the other side of the sternal border, 2nd intercostal space, for the pulmonic. Move down to the 3rd intercostal space for the Erb's point sound. Move down to the 5th intercostal space for the tricuspid. And staying on that 5th intercostal space, move over partway through the midclavicular line, right over here, to hear the apex or the apical heartbeat. You can refer to the slide that also has those pointed out a little more specifically on a different model. As you are listening, also listen for other sounds within the heart, which can be indicated by a murmur or a rub. A murmur is when there is excess fluid escaping between the valves of the heart rate. It sounds more like a swoosh sound. Those need to be documented. There are various murmurs, and the grading of those murmurs you will also find on the next slide. As you are listening to the heart, it's going to be important that you assess the rhythm. Is the heart rhythm regular or irregular? When you are listening to the heart rate, to fully assess it well, it needs to be listened to for a full minute, especially if it is irregular. You need to make sure that you are getting an accurate count. The rate of the heart is something else we need to document. That is the speed at which it beats per minute. Generally, a normal heart rate runs anywhere from 60 to 100 beats per minute, and that is normal. Anything slower than 60 is known as bradycardia, and anything higher than 100 is known as tachycardia. And those also need to be documented, and the physician made aware of those changes in normal. If your patient is being monitored, occasionally patients will have what we call a telemetry monitor on them, and they will have 5 patches on their chest, which their heart rate is being monitored by a telemetry machine, and you're able to record their strip. If the person has a telemetry monitor on, it's going to be very important that you note the rhythm, rate, and interpret that strip as frequently as policy calls within the floor or the hospital that patient is in. As we continue down with the head-to-toe assessment, the next thing we're going to be doing is that we're going to be inspecting the abdomen. Make sure that you expose the abdomen so you can see what you need to see when you're inspecting. We're going to look for any lesions, any striae, any artificial openings. If there seems to be swelling within the abdomen, we may want to measure the abdominal girth, which means we measure with a tape measure around the abdomen at the level of the umbilicus. Another thing we might want to do is observe for pulsations within the abdomen. Occasionally you will see the heartbeat as the abdomen will pulse. You may also see peristaltic waves as the bowels underneath are moving. Also, when we are looking at the abdomen, we divide it into different landmarks or different regions. Basically, you divide the abdomen into quadrants. The right upper quadrant, left upper quadrant, right lower, and left lower. That way, when we're describing different things throughout the assessment, we can refer to that quadrant. There are also 9 regions that you will find on the slide that go more specifically with pain. You may see some of those within documentation, and you may see just the quadrants used, but it's important to be familiar with each set. After you have observed the abdomen, it's going to be important now next to auscultate. With the abdomen, auscultation is always done after inspection as to not disrupt any of the bowel sounds that are happening within. So when we listen in all 4 quadrants, and we are listening basically for a gurgling sound to take place. Normal sounds usually vary. They're not constant or regular. Then they usually happen about 5 to 30 times per minute. Once you have heard sounds in one of the 4 quadrants, you move to the next quadrant, auscultating in all 4 quadrants. Bowel sounds themselves can also be hyperactive, which means they're moving quite frequently. Many times when a person is ill with different stomach flu, viruses, illnesses that are related to their GI tract, those may become hyperactive. Sometimes you can even hear bowel sounds from across the room. You may not even need your stethoscope. But there are other times as well when there's something going on in the abdomen that the bowel sounds may be absent. If there is an intestinal obstruction, that is one of the main reasons and main times you may not hear bowel sounds, as well as if the patient has had any abdominal surgery. That will cause the bowels to slow down or even stop for a while. And it's important for us as nurses to be able to tell and assess when they are back and moving again, because that is a very normal and healthy thing we want to have for our patients. After we have listened to all of the bowel sounds, next we will percuss all the quadrants. Generally with this, there's not air, shouldn't be air within the abdominal cavity, so it should be more of a dull percussive sound that we hear. When we have done with that, the last step is to palpate. We want to lightly palpate different areas throughout the abdomen, noting any masses or tenderness that the patient may experience. So as you're doing your assessment, it's important to speak with that patient and have them alert you if there's any tenderness that they feel. Another thing that you will see in patients who are having abdominal pain is abdominal guarding. So when you go to touch the abdomen, their abdominal muscles will tighten. Again, it's important to assess that to figure out why they are guarding and have them more specifically explain their pain to you. When we're also doing the GI assessment, it's important to talk about nutrition, habits of eating, also bowel patterns. When was the last time they had a bowel movement? Including the color and consistency, has that changed from normal for them? Is it more frequently or less frequently? And talk through the reasons as to why that might be. A normal person will have a bowel movement every 1 to 4 days. Sometimes when they're in the healthcare field or in the hospital setting, we need to really watch that closely because of different pain medicines that we give. This is one system that can be highly disrupted by that. So we need to make sure that they are monitored closely. Abnormalities that we need to discuss and let our physician know include black tarry stools, if the stools are pale, or if they're changing in consistency, becoming more constipated or more loose. We need to notify the physician and take the proper steps to help the patient correct that problem. As we continue down with the head-to-toe assessment, the next thing we're going to be assessing are the legs, or the peripheral vascular system. With this, again, we need to start with our inspection, the general appearance of the lower extremities. Again, we are comparing bilaterally as to note any swelling, changes in color or temperature. Cyanosis is something that we will see. Cyanosis is a bluish color to the skin and extremities. You can have central cyanosis, which is a bluish discoloration resulting in decreased oxygenation. Mainly they will see that around the lips and torso for central cyanosis. When we're looking more at the extremities, we're looking more for peripheral cyanosis. And that would mean that when their hands or the feet have more of a bluish tint and bluish color to them. If there is that, we need to make sure that we document the reason for it, if we know it, and what makes it worse or what makes it better for that patient. Also, we need to assess the capillary refill of the toes as well as the fingers. We will do that by just pressing on the nail bed and checking to see when the paleness goes away and the color returns again. In general, that should be less than 3 seconds for normal capillary refill. If it takes longer than that, we need to be concerned about oxygenation to the extremities. As we are also looking at the patient when we're talking about the vasculature and the different vessels, we need to note jugular vein distension. That can be noted when the patient is lying still. When they are at a 45 to 90 degree angle, you should not see their jugular veins within their neck. If we do, that can mean a cardiovascular issue that may need to be addressed. Also, when we're looking, as we're looking at the arms and the legs, we're inspecting again for any lesions, bruising, sores, open areas. Especially when we're looking at the elbows and the feet, we want to make sure that there are no pressure areas or redness, as well as behind the knees. We want to palpate any major arteries as well. We have to make sure that there's good blood flow to the extremities, and we do that by palpating the different arteries. On the slide that you will see that talks about the different arteries that need to be palpated. Some of them include the carotid, here in the neck, the brachial, in the arm, the radial, by the wrist. There's a femoral pulse located in the groin. The popliteal pulse is located behind the knee. Posterior tibial is located behind the ankle, and the dorsalis pedis is located on the top of the foot. Sometimes these pulses may be hard to palpate, and you may need a Doppler to actually get an accurate reading. Pulses are usually graded on a scale, 0 to 4 plus. Some of the scales vary. Generally, 0 means no plus, 4 plus means abounding. Normal range is anywhere from 2 to 3 plus. So you'll have to document accordingly to the scale that you are using. Again, as you are assessing different pulses, make sure you assess bilaterally within that person, so the right and the left extremities. Also, when we're checking for different vessels within the body, we need to assess for a Hohmann sign. That would mean a blockage within the vessels within the legs. To do that, we have the person flex their foot, point their toes up into the air, and ask about any calf pain or tenderness that they would have. If they would have pain or any swelling or redness within that calf area, that can indicate a blood clot within that leg, and further intervention would need to be taken as well. Also, as we are assessing the legs, we need to look for any edema or swelling that could be there. Is it bilateral? Does it occur on both legs? Does it pit? And by pitting, what I mean is when you press over bony prominence, do your fingered indentions actually stay within that skin area? If there is edema, we need to grade that edema, and that can be anywhere from 1+ to 4+, depending on the amount of indentation that our fingers leave within that site. Edema is generally a sign of heart failure, and patients need to be treated for that according to how much edema or excess fluid they have. So it's important that we document that thoroughly and accurately. If a person is bedridden, they may not always just have edema in their extremities. There may be edema located in their sacral area of their lower back and bottom. And so it'll be important as well, if they're bedridden, to roll them onto their side and make that assessment. When you're assessing the urinary system, the genital urinary system, it's important to not only assess the urinary bladder, but also to assess the kidneys. One way we also do that is to assess for tenderness within the flank area of our patients. The flank area is where the kidneys are located in the mid-back, one on each side on the right and left. You can percuss this area to see if they feel any tenderness. If there should not be tenderness in this area. So if they do say that there is tenderness and that hurts, that is an indication there may be a kidney infection going on or something more we need to evaluate. To continue with the genital urinary system, we need to also assess the voiding patterns of the patient, ask about color, amount, frequency, urinary characteristics of the urine that they are passing. Is there any change in frequency? Are they going more frequently or less often? Is there a normal amount? Or are they voiding in larger amounts than normal? What are the characteristics? Is it strong smelling urine? Is the color more concentrated? Is it a deeper yellow or more of a pale yellow? Questions they may want to ask by the nurse include frequency, urgency, and burning. Those are all characteristics of a urinary tract infection that needs to be investigated further. Also with urinary, we need to measure the output. Many times when patients are in a hospital or healthcare setting, we're needing to monitor what they're putting in as well as what they're putting out so we can maintain their hydration status. Output, generally, for a healthy person, we need a minimum of 30 cc's per hour that they need to be voiding. If a person has a Foley catheter, this can be done very easily assessed. If they do not have a Foley catheter in place, we need to make sure we are measuring their output in the appropriate receptacle. Also with the urinary system, we also need to assess the perineum. This doesn't have to be done specifically at the time of the head-to-toe assessment. Many times this is done when we are helping the patient to the bathroom or with their bath. If they have a Foley catheter, we need to pay particular attention to where that is inserted. Is there any excess drainage or redness caused by the catheter itself? Also, if they do not have a catheter, we need to note those same characteristics, as well as if there are any burning or irritation in that area. As we continue with the head-to-toe assessment, the health assessment, we need to also address the musculoskeletal system. This generally is done when the patient is up and moving or movement within the bed. We assess their gait. Is it steady? How well do they ambulate? Do they use any walkers or canes or any assistive devices to get around? Also, what is their range of motion? Are they able to move all of their extremities freely, or are there any areas that don't move quite so frequently or quite as well? We may need to do range of motion exercises as prescribed as well to make sure that all of their extremities move to the best possible. The more time a patient is in bed, or the longer they are in bed, the more stiff the muscles become and they lose mobility. So we do need to assess this area frequently as well. With musculoskeletal, we need to assess the CMS in all extremities. CMS stands for, C is the color, M is the motor function. Again, are they able to move that extremity in all extremities? Not just the general movement of the arms, but are they also able to move their elbows, wrists, and fingers, as well as the legs as we move down. Also, the S part of the CMS stands for sensory. Do they have feeling within their fingers and their legs? Is there any numbness or tingling? Have they lost sensation? All of those need to be noted as well. When they're up and walking, again, look for their ambulation or their gait, and make sure that we are documenting thoroughly how far they are walking and how well they are tolerating that, as that indicates how their progress is coming within the hospital setting. Activity, or ADLs, are another thing we need to address when we're looking at or talking about an assessment of a patient. What was their activity prior to coming into the hospital, and where will they be, or what are our goals for that patient? What are their goals in getting home? Are they able to walk the halls by themselves? How far have they walked? Are they able to brush their teeth and go to the restroom themselves? Are they able to eat, make their own meals? Those are all levels of activity that we need to assess, and therefore can help them reach their maximum level. When we're also looking at a patient, obviously we need to note any IV access. We talked about that briefly when we were looking at the skin and skin assessment, but we also need to note if they do have an IV that is running, make sure the IV site into the person is free of infection, redness, and swelling. We also need to make sure that the IV bag that is hanging is the one that is ordered for the patient and that it is running at the right rate that the physician has ordered. All of those are very important IV management things and I&O, intake and output assessments that we need to make. Also, during this assessment, we also need to look, are there any drains? Do they have a Foley catheter in place? Do they have an NG tube in place? Do they have a JP, Jackson Pratt, or a hemovac drain coming from a surgical incision? If so, those need to be monitored frequently. The output needs to be documented and the amount written down as well as assessed. Is that normal for the procedure that we are monitoring for? Also, if the patient is having any extra pain related to any of those sites, we need to make sure that we document that. As you conclude your head-to-toe assessment, it'll be very important that you maintain patient safety as a priority throughout all of it. Not only for the patient, but environmental safety as well. Make sure that when you are done, the bed is in the lowest position, the side rails are up, and the call light is within reach. It is also a good idea to make sure you have answered all the questions that they may have about anything that you have found or to discuss with them during the head-to-toe assessment. It is important that all this gets documented and documented thoroughly. Use as many descriptors as you can to identify any abnormalities that you have come across throughout the process. A thorough and accurate health assessment is an essential component to providing quality nursing care.